Thank you very much, Michael, for inviting me for your introduction. Thank you all for coming here today. It's a pleasure to be here. My first time in Sweden and Stockholm, and first time in 47 years. So, can you hear me? Or might not be on? Yeah. Oh, okay.
No?
Is it on?
There.
Oh, okay. Is that okay now? Better? Okay. So it's a pleasure to be here, and I don't know when I'll be back, so I'll tell you everything I know in 1 hour, as best as I can do that. So we chose a broad topic, controversies in manic depressive illness, and I thought I would focus on two basic aspects. In terms of diagnosis, as Michael just alluded to, a non-DSM-based approach to diagnosing mood illnesses. And specifically, I'll discuss mixed depression and mood temperaments. And in terms of treatment, a Hippocratic approach, which is perhaps different than what you expect from the term Hippocratic, and really comes down to questioning most of our current research in terms of its validity, and emphasizing maybe that there is much more than we think there is to lithium's benefits. So we'll start with the diagnosis. And I too started exactly the same years that you did in our field. And I also accepted DSM-3 and 3R and 4 without much doubt most of my career. It was really not until the last 5 years or so when the DSM-5 process started going and I began to interact with some of the leaders and some of the participants in the DSM-5 process. And I also finally met and interacted with some of the DSM-4 leaders who you may know, some of them were criticizing the DSM-5 process. I got to interact with them. For instance, there was a big conference in Copenhagen a couple years ago where a lot of those people were present, and I was able to be there and spend a few days with them, not just an hour, but hours and evenings in the bar with beer talking about DSM-4 and 5. And I learned some things I never heard before, never read about, never realized. And in fact, I became very disillusioned about our profession, more so than I already was. And now, the last 2 or 3 years, I've been starting to talk about it and write about it, although it's difficult to do, because some of these kinds of ideas aren't the typical kinds of things that you can publish in a scientific peer-reviewed journal. There are historical, really, facts or interpretations, and that's not what scientific journals are for. So I write about them in non-scientific journal settings, like newspaper essays and books, but I've started to publish some in the journals. If you are interested in sources for what I'm going to describe, there are a few new books that have come out about historical scholarship on the making of DSM-3. By historian Hannah Decker and another historian, Edward Shorter. Both of them went into the American Psychiatric Association archives and documented a lot of material from the 1970s and 80s that no one had known except the participants. They wouldn't necessarily agree with the interpretations that I'm making, but at least the factual documentation is in their books. I've also interpreted it on my own in my most recent book on depression. And I've said I've started to publish this in the scientific literature, so there's this new article in the Australian journal that I published where I discuss some of this. And for that and for any of the other articles of mine that I mentioned, I try to have them all on our website so that you can download them freely, toughsmood.com. So if you want to note that for your own later reference. Now, in the 1970s, the impetus for DSM-3 was legitimate in many ways because before that time, there was the problem of a chaos in psychiatric diagnosis, a complete lack of any organization to it, a complete anarchy. And to some extent, no one cared for some decades because psychiatry is very psychoanalytic. And from the psychoanalytic perspective, you just had a spectrum from neurosis to psychosis, and it didn't matter, really, to delineate diagnoses much more definitively than that. The treatment was always psychoanalysis anyway, so it didn't really matter. But as the drugs began to be developed in the 1960s and 70s, and people had drugs for psychosis and drugs for depression and lithium, there was a return of practical interest in saying who was really schizophrenic and who wasn't, and who was really depressed or manic and who wasn't. And some researchers who identified with Kreplin's ideas in the United States led this effort. They were primarily located in St. Louis, at the Washington University of St. Louis, which, as you know, is in the middle of the United States. It's not a major city or a major university. The major cities like Boston and New York and Washington and Los Angeles were all controlled by the psychoanalysts. It was in the countryside that the Kreplinian researcher started, sort of like Mao Zedong in China, started in the countryside and eventually took over the cities. So it was very political, really. In the 1970s, these groups started doing research using Kreplin's ideas to see if they could validate some of Kreplin's concepts as opposed to Freudian concepts. They had the problem that if you wanted to say that you diagnose a certain way, you didn't have a pathological specimen in psychiatry. You couldn't go, as in some branches of medicine, to the tissue in the organ, in the liver or wherever, and say, yes, it's hepatitis because, see, you can confirm the clinical symptoms based on this pathology. In the absence of a pathology, the clinical epidemiological standard was to identify multiple independent sources of evidence that point in the same direction. Besides symptoms, genetics, course of illness, and then biological markers, which if you did not have them, you could use treatment response in a way as a pharmacological probe for biology. Of course, you had to be careful about that because many treatments are nonspecific. Some even work in everybody, like amphetamines or benzodiazepines or opiates. So a treatment effect does not translate into a diagnostic validation, but it can under certain circumstances. More importantly, course was very important, and that was emphasized the most, as Kreplin had always said, that diagnosis is prognosis. If you don't know what the diagnosis is, follow the patient for a few decades, and then you'll figure it out. And that's what he did. Of course, if you want to treat them in the beginning, that's a practical problem. But from a purely scientific perspective, the prognosis, the course, will tell you the diagnosis, the outcome, the number of episodes, is it episodic, what age did it start at. Now, the genetics was always considered relevant for some conditions, at least, that were considered relatively genetic, like schizophrenia and maybe manic depression. Now, all of these sources of evidence were used to validate symptoms. So the DSM-3 grew out of this kind of research, some of it, that validated defining schizophrenia a certain way versus other ways because of genetics, course, and outcome, and even biological markers. But the interesting thing is, even though they used genetics, course, and biology and treatment to validate the DSM-3 definitions, they didn't put genetics, course, and biology in the DSM-3 definitions. They only put the symptoms. There's a couple exceptions. There's a course criterion for schizophrenia. But the vast majority of DSM-3, 4, and 5 criteria are purely cross-sectional symptoms. But they're not based on cross-sectional symptoms. They're based on course, genetics, biology, and treatment. But people have forgotten that because the textbook itself, the DSM book itself, the criteria themselves are just symptoms. So people act as if the symptoms are all that matter. My typical question is, suppose you have pneumonia with chest pain and you have pneumonia without chest pain. Are those two different illnesses? The symptoms are different. Why don't we call one bipolar pneumonia and the other one unipolar pneumonia? Symptoms are different. You have to say that the symptoms are diagnostically important based on some other criteria besides the symptoms. So how do we know that it matters if somebody is bipolar and has mania and depression versus somebody who's unipolar and doesn't have mania, just has depression? How do we know that those are different illnesses? It's not just because the symptoms are different. The claim was that they differed in their genetics and their course and their biology and their treatment. That's what the research from the 60s and 70s suggested. Now that was rational if the evidence supported that. A lot of that research was done by Jules Angst and was published by him, was one big study, the Zurich cohort, which he's still doing. And the second major study was published by the Italian researcher Carlo Paris in the Acta Psychiatrica Scandinavica in 1966. Those two big studies influenced the transition to the bipolar unipolar concepts, which I'll get to more. So there was some science to it, and the science led to the research diagnostic criteria, which were about 20 diagnoses. But those 20 diagnoses in 1978, or 16 or so, almost 20, became 292 in 2 years when DSM-3 came out. Now, there's no way that we suddenly discovered 270 illnesses in 2 years based on scientific research. And the fact is, it wasn't. The science supported 16 diagnoses. DSM-3 gave us 270 more. If you just divide those numbers out, it tells you that DSM-3 was 91% unscientific by definition. So people say, is DSM scientific or not? Well, it's 91% unscientific. It's 9% scientific, sort of. It's not all or nothing. And then in 14 years, we added another 70 or 80. And then 20 years later, since we're really afraid to change, we've only added a couple of dozen more. So we're at about 400. But if you ask the question, go to the scientific literature for these 400 diagnoses, how much evidence do you have on symptoms, course, genetics, biology, and treatment effects that these are different from each other and validly different? The answer will be that you don't have that kind of evidence for more than 10, maybe 20% of the DSM labels that we use. So where do the other 80 to 90% come from? They come from what the DSM-4 leadership has been most explicit about, this pragmatic criterion. The pragmatic criterion means that they make changes based on what they think is best for the profession. That's what I learned in the last few years, and I'll explain to you more in the course of this talk. Let's go back to how this all affected mood illnesses. It is important to realize that before 1980, before DSM-3, we had the concept of manic depressive illness, and we had other depressive presentations, neurotic depression, melancholia, as Michael mentioned. And what we did in 1980 was to say that all of those different depressive presentations, plus the majority of patients that we called manic depressive, should be relabeled major depressive disorder. And a very small minority of the manic depressive patients should be labeled bipolar. So one very important fact for you to understand that many people don't seem to is that bipolar disorder, the way we talk about it, is not the same thing as manic depressive illness. Bipolar disorder is not the same thing as manic depressive illness. Manic depressive illness meant depression or mania that was recurrent, severe, and episodic. Bipolar disorder means depression and mania that's recurrent, severe, and episodic. The whole difference was in one word, a conjunction. If you convert or to and, you have the difference. So if you just diagnose somebody today with recurrent depression, if they have 5 depressive episodes that are severe and episodic, you'll diagnose them with major depressive disorder, right? If that's all they have. Well, that's what used to be diagnosed as manic depressive illness. Manic depressive illness did not mean mania and depression. It meant mania or depression. The only requirement was that it was episodic and recurrent. It didn't matter what the polarity of the episode was. Now, the reason for that, which I'll show you in a little while, is that Kraepelin believed that there was no polarity to the episode. It didn't matter if the patient was manic or depressed, because patients are not manic or depressed. They're both, usually. They're mixed. You can't distinguish the two. Therefore, don't even bother trying. That was Kraepelin's view. And I'll show you some recent research that may indicate that he was right after all. So these were the patients that were called endogenous severe biological depressive patients. These severe unipolar depressive patients, they were considered psychotic, in fact, in many of the research studies. In Leonhardt's studies, they were limited to psychotic patients. But DSM said, oh, they could be non-psychotic too. And they could even be mild to moderately anxious, and chronically so, as the neurotic depression concept was. So DSM mixed all sorts of depressions, from the mildest and the most chronic ones to the most severe, episodic, even psychotic ones, which nobody had ever considered to be the same. And why did they do that? Because they simply put polarity above everything else. If you're depressed and that's it, end of story. If you're manic and depressed, you're a completely different entity. Now, there was some research evidence to support that, like I said. But the interesting thing is that evidence wasn't as definitive as people think. There were these two big studies that I mentioned in 1980. And there's been 30 more years of research since then. And one of the most interesting facts is the same researcher, Jules Angst, is still doing research with the same group with 30 more years of data. So it's a lot better data than he had in 1980, and it's showing the reverse. You can't distinguish bipolar and unipolar patients often based on their course and on their genetics. Now it's showing the reverse. And so he went to the DSM-5 task force and he said, you know, my data now shows that this bipolar MDD distinction isn't so clear-cut. We should have a spectrum. And they said, no, we can't do that. And my question to them is, well, why could you do that in 1980 when he had less data, and you won't do it in 2014 when he has much better data? Why? If it's just based on the science, why not? Because it's not just based on the science. Well, you can see if you have many, many types of illness that are all diagnosed in one category, you're going to diagnose a lot of people with that condition, MDD. I want to give you a sense of some of that genetic research here, where when they looked at patients who were bipolar versus MDD, what you had in bipolar patients was inheritance of bipolar illness, type 1 or type 2. But you also had a lot of depression, unipolar depression. In MDD, you had unipolar depression. You didn't have bipolar illness. The unipolar depression did not distinguish the groups. In other words, the genetic difference is not in both directions. Unipolar depression is nonspecific genetically. It does not run in families of unipolar people. It runs just as much in other people, bipolars, for instance. What differentiated the two was a bipolar family history. So here's the problem. I face this problem a couple times a week with new patients. DSM system is entirely based on the view that if we have these two big mood categories, and they're based on genetics and course. So if you have bipolar patients, you should have a bipolar family history. If you have unipolar patients, you should not have a bipolar family history. But I keep seeing all these unipolar patients with bipolar family histories. These patients with recurrent, severe, episodic depression, but they have bipolar illness in their family. So there's only two possibilities then. Either that patient does not exist, the one who's sitting there in front of my eyes, or the DSM system is wrong. The only two logical possibilities. Having unipolar depression with a bipolar family history is like having a squared circle. It's a logical and biological improbability at the very least, if you don't want to say impossibility. Highly improbable. The whole diagnostic system is based on the view that that kind of thing doesn't happen. It's like having an Alzheimer's patient whose cognition gets better. We have all these Alzheimer's patients whose cognition improves. It's like having, well, it's defined to not happen. So if it's happening, there must be something wrong with our definitions. So MDD is a spectrum. It's a broad mix of things. There's the neurotic patients. There's the classic severe melancholics. They're very psychomotor retarded, very anhedonic. And then there's this mixed group, which I'm going to talk about. And then maybe there are really purely depressed patients, but they're not the majority. So the secret of DSM is this pragmatism concept. This concept that why you decide to make a change in the criteria is not primarily based on the science. If it was, Angst's research from 30 years more data would lead to changes now towards spectrum models, but nobody wants spectrum models among the APA and DSM leadership. Why? Because they don't want to diagnose more patients. Why? Because it's not popular to do that. Why? For various reasons, one of which is stigma in the public. They're already diagnosing 25% of the population with current DSM definitions. They don't want to diagnose more because then they'll be accused of pathologizing and diagnosing too many people and trying to get more power and trying to sell more drugs. It's unacceptable. Well, why is it acceptable that 100% of the population is diagnosable with physical illnesses at some point in their lives? but only 25% would be allowed to be diagnosed with mental illnesses. Why? Who set the bar at 25? Well, the reason they do that is they set up this disorder concept where you have to have functional impairment and severe symptoms to meet diagnostic definitions. Why? What's the scientific rationale for that? Do you remember how we used to diagnose headache before the 1950s and 60s? You could have a blood pressure of 250 over 150 every day for years on end, like Franklin Roosevelt did. But if you didn't have, diagnosis of hypertension. If you didn't have headache, if you didn't have some symptom from the high blood pressure, you were not diagnosed with clinical hypertension. You had to have a symptom. You had to have functional impairment and severe symptoms. It's not enough just to have a high reading on your blood pressure. That's pathologizing. Then, of course, he got a severe headache and he died 5 minutes later from the stroke. So he was diagnosable 5 minutes before he died. And that's the kind of thing that led physicians to change their definitions of hypertension in the 1950s and 60s away from the requirement for symptoms and functional impairment. That's not biologically rational to have that kind of requirement. Well, why do we have that requirement for every single psychiatric disorder? Because we're not basing it on biology and science. We're basing it on political, economic, and social considerations. I think that this whole term disorder is useless. I try to use it as little as I can. It's explicitly vague. It's meant to be vague. It was introduced with DSM-3 in 1980, as Michael was saying, because they don't want to commit, the leadership of the APA and of our profession, don't want to commit to anybody saying that anything's a disease or anything's not a disease. They don't want to commit to any of that. Well, what are we going to say then? We'll call it a disorder, and if you want to treat it like a disease and give them pills, you will. And if you don't want to treat it like a disease and not give them pills and give them therapy, you will. And you're free to do whatever you want. Well, that's nice. You're free to do whatever you want, but is that the way science functions? You can just decide to do whatever you want to? I think the law of gravity doesn't exist, so I'll just jump off the building. I'm free to do what I want to. That's not the way science is supposed to function. It doesn't mean you have to be totalitarian about it, but the evidence needs to be accepted when it's strong enough for something. So sometimes we might find that some of these illnesses are diseases. People have an allergic reaction to that term. Disease process, Kreplin called it. Why can't we use that term, Krankheitsprozessen? Why do we have to say that bipolar illness is not a disease? Or schizophrenia is not a disease? Does anyone really believe that based on 100 years of scientific research? And why can't we say that some things are not diseases? Clinical pictures, Zustandbilden, he called it, and the Germans called it back then. You have a clinical picture. This kind of patient population exists. We don't know what it is. It's probably not a disease, but we're not really sure what it is. People get sexually traumatized, and then they have unstable relationships, and they cut themselves. We don't know what it is, but we see patients like that. They used to call it hysteria. They had other terms for it. We call it borderline, but that's not a disease. It's a clinical picture, which used to be called something else. Why do we think that that's equal in conceptual terms to schizophrenia, which is a disease that's existed for hundreds of years and has always been viewed that way, or manic depression, which has been described pretty well for 200 years the same way and longer? I think we're afraid to commit. We're afraid to draw conclusions. It might have been fine in 1980 when we didn't know much. We actually did know a lot then, but let's pretend that we didn't know too much. But what are we doing all this research for 30 years, 40 years? Why do we have these research centers like here and like Harvard where I've worked if we're not going to ever draw any conclusions from any of this? We're just going to keep calling things disorders for another 40 years and pretend that we don't know anything about them? We've stood still since 1980, and that's totally unacceptable for a scientific profession. Science is supposed to be about progress, and again, some people don't want to admit that, but if you're not progressing, you're not really being helpful. There is another aspect to this. This pragmatism also reflects postmodernism. I won't get into that much now, but postmodernism is a cultural ethos that's deep into our culture. We are all postmodernists, so you don't have to read something about it. You're born with it. It's bred into you. Just like 500 years ago, everybody was very religious. Right now, we're all postmodernists. And part of postmodernism is a deep skepticism about science and truth and progress. And a lot of our DSM leaders, in my observation, especially the ones who were non-researchers, have a very deep skepticism about research and about science. The leader of DSM-4 is explicit. He says, the last people that should be involved in defining DSM criteria are the scientific experts. They're the last people. They're the ones you should listen to the least because they're the most biased. They all just want to expand their own diagnoses because they want power and they want money and they want prestige. That's the postmodernist perspective. What Nietzsche said, everything's about power. There's no truth at all, and there's no progress. So once you accept all that, and science becomes just another activity, it's not any more important than playing golf, you know. It's not any more true than anything else, than linguistics, than literature. Then, of course, you make it up how you like to because there's no truth to it. Of course you can be pragmatic. But if you take science seriously, then the whole DSM system is set up opposed to you. Now ask yourself this question. Why would genetics and nature and biology and pharmacology follow the definitions of the late 20th century leadership of the American Psychiatric Association, who define things a certain way because it's acceptable in our culture and we prefer it this way? Why would genetics follow those definitions? So we define MDD a certain way based on these social considerations. And we define bipolar a certain way based on those considerations. We define ADD a certain way based on social considerations. We define temperament dysregulation disorder a certain way, oppositional defined disorder, and so on and so forth. Well, if you do genetic studies of those made-up socioeconomic, socially constructed labels, if you do genetics of that, do you think the genetics are going to be consistent and positive? If you do neuroimaging studies, do you think they'll be positive? If you do pharmacology studies of a specific drug mechanism, like, say, serotonin reuptake inhibition, do you think they'll be consistently strong and positive? On labels that you've made up for political, social, and economic reasons, not for scientific reasons? So this is what has dismayed me the most. I've come to the conclusion that the reason we haven't made so much progress in the last 30 or 40 years in biological research, most of which is unreplicated and mixed, pharmacological research, which, as we know, as we'll talk about some, is very weak, and genetic research, which famously has been negative, you know, in a large sense, a lot of non-replication. A major reason that we failed is not just because it's complicated. People say the mind and the brain are complicated. It's not just because of that. It's because our DSM system dooms us to failure. It prevents us from having any success because our phenotypes are not scientifically valid. If your phenotypes are not scientifically valid, your genotypes will not be valid, and your pharmacological treatments will not work out. So it becomes a self-fulfilling prophecy. They say there's no truth out there, and then they set up a system which prevents you from ever finding out what the truth is. If we were to do it differently, we might pay attention to the fact that schizophrenia and bipolar have a heritability that's much, much higher than anything else, including MDD, which I know it's not so straightforward to relate heritability to disease processes, but this is genetic heritability based on twin studies. It's suggestive that we're dealing with something that's more of a disease process. We might go back to having 10 diagnoses like the original Kreplinian researchers of the 70s suggested instead of 300, and that's plenty. You would capture the vast majority of your patients with 10 diagnoses like that. We might use a hierarchy concept instead of a comorbidity concept, where we say if you have illnesses that cause lots of symptoms, you should try to treat those first before you diagnose all these other conditions and treat them. And we would treat patients with many fewer medications if we took that approach. I don't know why this is controversial, except again for the fact that it goes against the wishes of the political leadership of our profession for the last few decades. But you'd be a very bad physician if a patient came to you with pneumonia and you diagnosed him with fever disorder, chill disorder, night sweat disorder, and gave him a different pill for each one of those symptoms. But patients come routinely with manic depression, and they get an antidepressant, an anxiolytic, an amphetamine, and a neuroleptic for all their different symptoms. And they get diagnosed with GAD and ADD and all these other things. So I think that's one way out. It's an old idea that was directly rejected by DSM-3, but I think that it makes sense to me. Now, I did want to touch on a few other things in relation to diagnosis. People have claimed that bipolar is overdiagnosed. And this is another rationale for not allowing diagnoses to be based on some of these scientific spectrum concepts that some of the research supports. One of the most common claims is in children that the diagnosis increased 40-fold. But what people don't often note is that it started at 0.01% and it went to 0.4%, which is a 40-fold increase. That's still below the actual epidemiologic prevalence rate of 0.5%. This is not to say that some of these kids weren't misdiagnosed, but that means that there are plenty of kids who have it who aren't diagnosed, because the actual rate is still here or above. So to claim the illness is overdiagnosed, at least on the basis of saying it's diagnosed more than it actually exists, isn't true. There's no scientific evidence for that, and not in kids. We did a small study where we looked at this. We published it in 2009. And we compared ADD patients, major MDD patients, and bipolar kids diagnosed by the child psychiatrist researcher that I was working with who used DSM criteria. So obviously you have to accept that level of, those diagnoses might have been valid. And then we looked at the histories of these kids and treatment by other clinicians. And as you can see, ADD was diagnosed in everybody who had it and many people who didn't. MDD was diagnosed, and most people had it, and some people who didn't. Bipolar was the only diagnosis that wasn't diagnosed in the majority of kids. It's useful to have a control group if you're claiming overdiagnosis. This is actually the only study that has a control group in kids. And we found underdiagnosis, not overdiagnosis. Another thing that people don't realize is that bipolar illness in kids means depression. It doesn't mean mania. If you follow 10-year-old children for a decade, half of them develop manic episodes after having just had depression. 10-year-old depressed children, MDD kids. Half of them develop manic episodes by the time they're about 21. If you follow 23-year-old severely depressed young adults, 40% of them develop manic episodes by their mid-30s. Just MDD, so-called MDD. The point of MDD from the course perspective was that it did not begin in childhood and young adulthood. It began in middle adulthood, around age 30 was the average age of onset, and based on ONC studies and Paris studies from the 60s and 70s. Bipolar disorder began average age 19. That's been very consistent for 100 years. 1/3 of bipolars start in adolescence. That's been described since Fauret in the mid-1800s in Paris. This is not a new American thing. A lot of people say the Americans are diagnosing it. The British really like to say that in particular. But you have an illness that's been defined as starting in adolescence and early young adulthood. And then they say that unipolar depression is different because the course is different. It starts later. Well, then how can you have unipolar depression in a 10-year-old? Again, if you do, and if you have a lot of it, and you actually do, half the kids are still unipolar 10 years later. But if you do, then that goes against the distinction between unipolar and bipolar. It goes back to the concept that maybe the manic depressive concept is correct, that you really can't distinguish these conditions very well based on genetics and course. And it also reminds you that therefore this recurrent severe depression in kids may not really be so different from bipolar disorder as everyone wants it to be and everyone's all worked up about. Even in adults, this is Zimmerman's paper. We had a little debate with him that was published in the British Medical Journal where Dan Smith and I commented on it. In this study, they claimed that bipolar was overdiagnosed because only 43% of clinically diagnosed bipolars could be confirmed to have it using the research interviews. What they didn't say was that in their own data, which we reanalyzed, the bipolar patients were this small bars here. There was about 90 of them. but only 1/3 of them were actually diagnosed as having it. In other words, the researchers said these 90 people had bipolar, but the clinicians only said 1/3 of them had it. So the claim that it's overdiagnosed, if you actually look at the other way around, is how many of the bipolars that really had it were overdiagnosed or not diagnosed. You don't see that. What you see is that there was 30% of the bipolars who had it who were diagnosed with it, and 13% of people who didn't have bipolar were diagnosed with it. And so really, there was twice as much patients who were underdiagnosed as opposed to overdiagnosed. Twice as many people have bipolar and don't get diagnosed with it as don't have bipolar and get diagnosed with it. That's what their own data showed. So it's not just about looking at what clinicians say and then what they say. That's reliability. A reliability of 50% is de rigueur. Kappa values will be about 0.2, 0.3. That's what it is for MDD, according to the DSM-5 field trials. This doesn't show bipolar is overdiagnosed. If this shows bipolar is overdiagnosed, then MDD is overdiagnosed too. Everything's overdiagnosed. But I think what's more legitimate is to say, what's the validity? If you take patients who really have an illness, how many of them are diagnosed with it? And what you find is that there's a 30% underdiagnosis rate in bipolar illness. I think I stated that wrong. There's a 30% underdiagnosis. 27 out of 90 were not diagnosed. 70% were. And we found that as well, that there's a 40% misdiagnosis rate. We've published some research. We've shown it takes twice as long, 2 to 3 times as long to get diagnosed if you're bipolar as if you're unipolar to get appropriately diagnosed. We've published this repeatedly. So there are no data in adults either that show that bipolar disorder is more frequently diagnosed when it's not present than not diagnosed when it is present. The underdiagnosis rate is 30 to 40%. So I think it's still a problem, but again, it goes back to some extent. People don't want to diagnose it because they're really caught up on the bipolar label and distinguishing it from MDD. And in fact, that whole issue, distinguishing these two conditions, the way DSM-3, 4, and 5 have done it, is something that with a couple of decades more research is questionable, I think. One of the things that makes it questionable is the research on mixed depression. Mixed depression has been narrowly defined in the DSM system, including the current mixed modifier in DSM-5. But broader definitions exist, which I want to show you. I want to especially emphasize for you Koukopoulos' definition of mixed depression, which is patients who have depression, anhedonia, suicidality, low interest, a lot of the core depression symptoms, but it's mixed with psychomotor excitation. Psychomotor excitation. So they're agitated, they're restless, they're pacing, they're angry, they're irritable. And they may also have some classic manic symptoms like periods of increased libido, hypersexuality, increased talkativeness, racing thoughts. Now, you don't have to have it all the time, the way he's thinking about this kind of mixed depression. You might have a 4-month depressive episode, and then for 2 or 3 days of it, you're hypersexual and talking really fast and running around. And then the other 3 months and 3 weeks and 5 days, you're down. Well, DSM says ignore the 2 days. Doesn't mean anything. Well, how do you know it doesn't mean anything? Maybe it means something. The other thing is you could be really agitated and angry the whole time and excitable. And that's a very different kind of depression than melancholia, where you're slowed down and you're not angry or agitated at all. At least symptomatically it is. Maybe diagnostically it's different. The other definition that comes from Angst is what he calls the bipolarity specifier, which is more the brief 2 or 3 day period that I mentioned to you of more classic manic symptoms. So he did this bridge study, which you may have seen that was published, where in a large international sample, he found that about half of patients with major depressive episodes, irrespective of whether they're unipolar or bipolar, most of them are unipolar, about half the patients with depressive episodes have manic symptoms, multiple manic symptoms, but very briefly. Not for 4 days or a week or 10 days or 2 weeks, but for a day or 2 or 3. Does that not count for anything diagnostically? Well, he looked at some validators. in those patients, you have much higher rates of family history of bipolar illness and very high rates of antidepressant-induced mania. So you have both genetic and treatment validators. That it means something. It's more like bipolar illness. It's not bipolar disorder by DSM definitions. But DSM says, look, if you have 1, 2, or 3 days of mania, ignore it. Doesn't mean a thing. Who says? Why? There's zero evidence that the 4-day criterion for hypomania is scientifically legitimate. Zero. There's plenty of evidence that you could argue for a 2-day criteria. Maybe 3, but 2 definitely. And in fact, the DSM-5 task force recommended that the hypomania criteria be lowered to 2 days, and it was rejected by the DSM-5 leadership. The scientific evidence supports it. The task force recommended it. Leadership rejected it. Why? For pragmatic reasons. They don't want to diagnose bipolar disorder more. Now, this mixed concept is especially relevant, I think, to this larger issue when we think about the fact that once you start viewing mixed states broadly to include dysphoric mania, which is a term we used to define, and these kinds of agitated and mixed depressions and the bipolarity specifier, that's about 60% of all mood episodes in people with severe mood episodes. It's about 60%. It's the majority. It's a minority, about 20%, that are purely manic and purely depressed. The majority are mixed. And this confirms Kreplin's view. He had 8 mixed states, and he had pure depression and pure mania, and he kept emphasizing that most patients are mixed. That's why he did not, I mean, he wasn't unintelligent. He could have defined the diagnoses on polarity if he thought that's the way to do it. But his rationale was, at least it seems to me, in rereading him through the lens of this other research, his strongest rationale was, there's no polarity upon which to base your classification. It's all mixed, or the majority of them are mixed. That's not to say you don't have any pure episodes, you do, but they're infrequent enough that it's illogical to base your diagnostic system on what happens in the minority of patients. Now, we've shown that this mixed depression is therapeutically important because we did the first placebo-controlled study with a dopamine blocker, so-called antipsychotic, versus placebo in mixed depression, defined the way Angst has it as bipolarity specifier, in a mixture of bipolar and unipolar patients, more unipolar than bipolar, and we showed that it was effective. Ziprazidone's been shown to be ineffective in bipolar depression, the way DSM defines it. We found it effective in mixed depression. And that gets at this issue of, if you have this very broad heterogeneous depression concept, you might be dooming your pharmacology research. You're not going to see the efficacy when it's more specific to subtypes. So it seems that dopamine blockers are very helpful for this kind of agitated mixed depression. In contrast, antidepressants seem harmful. And we have only circumstantial data so far because we haven't been using these definitions to do research. But if you look at the Stanley Foundation's randomized clinical trial of antidepressants in bipolar depression, treatment-emergent mania happened more if patients had even just 4, a score of 4 on the Young Mania Rating Scale, meaning this kind of mixed depression, a little bit of psychomotor excitation along with depression, makes you much more likely to get manic on antidepressants. And you not only get manic, you get more mixed. You're already agitated and angry and restless and suicidal and impulsive, and then you get the antidepressant and you're jumping off the building, as one of my good friends did, who had a mixed depression and got lots of antidepressants. You kill yourself that way. That's what Dilsaver found in these classic studies of mixed states, that mixed states have at least as much, if not more, suicide potential as pure depression. When people say people commit suicide because they're energized when they're depressed, well, what do they mean by that? How can you be energized when you're depressed? Depression is a state of psychomotor slowing and retardation. If you're energized when you're depressed, you're not depressed. That's a manic symptom mixed with a depression symptom. You're mixed. So mixed depression is, I think, a very important clinical issue that we need to start thinking about more. For me, it has really changed my practice a lot in the last 5 years. And I learned about all this a great deal from Koukopoulos, who was a Greek researcher in Italy for decades who just died last year. And it became more and more clear as he aged that his experience was right, that he was really bringing it home, that's teaching us. And now we have access to his database, and we're publishing from his patients who he followed for 4 decades, and we're showing some of this evidence, and it's coming out gradually. Now, mood temperament is the other thing I want to discuss. It relates to personality. You know, you can talk about personality disorders, which come from the psychoanalytic tradition. But mood temperament is a different way of thinking about personality. It's about the original concept, which came from Kahlbaum and then was popularized by Kretschmer in the early 20th century. Kahlbaum came up with the terms, but Kretschmer really emphasized them. The idea that Kretschmer had was that dysthymia is a mild version of depression. Cyclothymia is a mild version of mania and depression. Hyperthymia is a mild version of mania. And schizothymia is a mild version of schizophrenia. And they are all literally mild versions of those illnesses that get transmitted in the families of people who have those illnesses. And furthermore, people who have those illnesses can have these mood temperaments in between their severe episodes or exacerbations. And it's been very well shown that schizotypal personality is a genetic variant of schizophrenia and a mild version of it. There's emerging research that shows that cyclothymia, hyperthymia, and dysthymia are much more common in families of people with bipolar illness than not. And we've done research that's shown that half the patients in our clinic who have bipolar illness also have cyclothymic temperament, most commonly, or hyperthymic temperament, or dysthymic temperament. These are mild symptoms that are present all the time. Now, if you're cyclothymic or hyperthymic, you're going to be revved up, distracted, talking fast, thinking fast, pretty creative, energetic, productive, a workaholic. You might have trouble with relationships because you're so revved up and externalizing all the time. And since the DSM definition of borderline personality doesn't include sexual abuse and only has self-cutting as one of multiple criteria, you easily meet the definition for borderline personality if you have hyperthymic temperament or cyclothymic temperament. And then the problem is, how can we tell who's got bipolar illness, say, and in between their cyclothymic and hyperthymic, as opposed to having comorbid borderline personality and bipolar, or just having borderline? Well, we can tell that, I think. Just mentioning here personality traits is another way of looking at personality that has tons of research behind it, does link into the mood temperament concept a bit, but it's more dimensional. And again, it was recommended by the DSM-5 task force. It actually was approved by the DSM-5 leadership, supported by them, and within a few weeks of the final vote on DSM-5, it was rejected by the American Psychiatric Association Board of Trustees. Kind of like the Politburo saying, no, we're not going to take it. It's not a scientific decision, but the science is really strong for it, but it's not in DSM-5, at least as a primary concept. We can distinguish, I think, these mood temperaments from borderline because sexual trauma is at least 2-fold, maybe 3-fold more common in borderline personality than bipolar illness or the general population. And self-cutting is, depending on the study, at least 2-fold, maybe 50-fold more common in borderline personality than in bipolar illness. Now, the borderline experts often try to downplay sexual trauma and self-cutting these days. They just emphasize the mood lability and the unstable relationships. Well, every bipolar has mood lability and unstable relationships, so that's really not a good way to differentiate borderline from bipolar. And they'll say, well, some people with borderline personality don't have sexual trauma. That's true, but the majority of them still do. And of course, that's a highly underreported and controversial issue about knowing if you've had sexual trauma. Self-cutting is very consistent. It's about 70% or so of the borderlines, and much, much less in the bipolars. So I think that we should emphasize these kinds of diagnostically differentiating validators, not just the symptoms, not certainly the DSM symptoms. Again, the whole concept of borderline personality grew out of people who had sexual trauma and who were self-mutilating. But then those terms aren't used for the diagnostic criteria. In the Bridge study, it was shown that these mood symptoms don't differentiate bipolar and borderline or mixed states and borderline, but the non-mood symptoms, especially the self-mutilating symptoms and the dissociative symptoms, did. if we started thinking more about hyperthymia and cyclothymia, we would maybe also appreciate that many of our patients and their relatives have it and have benefits from it. So here's the only picture of Franklin Roosevelt in a wheelchair, a man who I tried to show in my biographical description of him had hyperthymic temperament. Very funny, very creative, very talkative, very high sex drive, very charismatic, very energized, low need for sleep. And that helped him survive polio. There's research, emerging research that shows that when people have traumatic experiences, their likelihood of developing PTSD is lowered if they have hyperthymic temperament premorbidly. And also, you know, his personal trauma he got over, and I think my view is that hyperthymic leaders help nations survive political traumas. In his case, the worst of the century. The two worst things, the worst depression economically we ever had, and of course World War II. Now, a lot of people will diagnose this hyperthymia or cyclothymia as adult ADHD because when patients have manic symptoms, they can't focus. And people say adult ADHD is really prevalent. People like to say that half of the kids continue to have it when they're adults. Well, if that's true, I wonder why 9 prospective studies conducted before the pharmaceutical industry got involved in this field showed that there was a 90% decline in ADHD by the time you reach young adulthood. The introduction of Strattera, atomoxetine, in 2002 as the first FDA-indicated drug for adult ADHD led to the marketing of adult ADHD. Recent research studies suggest there's more frequency of it, but still, the earlier studies don't find that. I'm going to show you some newer data too. The other thing that makes me wonder about this concept that ADHD is purely biological and really persistent is that in the United States there's a good deal of state-to-state differences. So ADHD rates are very high in the southern states, which are the poorest states in the US, and very low in the western states, which are somewhat wealthier and people tend to go outside more and exercise more and so on. So for instance, you have literally a 3-fold higher rate in some of these southern states than you do in California. This actually mirrors the map for diabetes and heart disease, which shows that there are, generally it's thought of in clinical epidemiology as reflecting environmental factors like diet and exercise that influence behavior that then influences behavioral symptoms. It's highly suggestive that ADHD, just like heart disease, has important environmental factors involved. And I always wonder why the cardiologists are more behaviorally minded than the child psychiatrists are. The child psychiatrists want it to be purely biological. We have this recently published 33-year outcome study. What happens with kids who have ADHD at age 8 with a control group followed until they're 41? How much of it persists? And the answer is 20% persists, 80% does not. So still our best research is that the majority of kids with ADHD do not persist into adulthood with it. What's also interesting is that the biggest group that did have problems became antisocial, and that there was a good substance abuse rate. I suppose those aren't really good things to have as adults if you're taking amphetamines for 20 or 30 years. There was some mood illness as well. I mean, some of these kids develop mood illnesses as well. The substance abuse rates, by the way, people like to say that substance abuse does not increase with amphetamine use in children. That's not true. It's not true based on the only randomized data which we have, which is the MTA study, which actually found higher rates of substance abuse in the kids randomized to amphetamines versus the kids randomized to behavioral therapy at 1 to 3 year outcome. So we're going to talk about amphetamines in a second, but I just want to make the point that when you start thinking about amphetamines because of adult ADHD, you might be making a diagnostic judgment that isn't valid, partly because we're misinterpreting mood temperaments, perhaps, as ADHD. And we're also influenced by beliefs about persistence of ADHD, which isn't really well supported scientifically. Now, a few words on treatment, and then I'll stop. I don't like the words we use for drugs. I don't like antipsychotic, mood stabilizer, and antidepressant. They were clinical terms invented in the 1950s and 60s when we didn't know what the biological mechanisms of the drugs were. And they're definitely not true. Antidepressants don't work for all depression. Antipsychotics work in non-psychotic persons. And mood stabilizer doesn't mean anything scientifically meaningful. It's just a linguistic term. I've suggested that maybe we should use biological mechanisms and call the antidepressants monoamine agonists. You know, like we say SRI. I think that's a better way of talking about them. They work better in anxiety than they do in depression anyway. We could use dopamine blocker for the antipsychotics. We could use second messenger modifiers for lithium and valproate and some of these drugs we call mood stabilizers, and GABAergic agonists for the anxiolytics. And I think that would imply fewer assumptions when we talk with ourselves and with our patients. I've started talking to my patients this way, and it helps. I don't have to say, yeah, you have bipolar depression, but I don't want to give you an antidepressant. I say, you have bipolar depression for which monoamine agonists are ineffective. It's a much better way of talking. I don't have to say, I'm going to give you a mood stabilizer, and then they're afraid I'm going to make them a zombie. I say, I'm giving you a second messenger modifier to prevent your mood episodes. It's much more scientific, much fewer mistaken assumptions. Something to think about. I proposed this, and so far I've had this paper rejected a number of times, and it's not published yet. So I don't know if it'll ever, where I'll get it published, but I tend to do it eventually somewhere. Sometimes it takes a decade. All right. In terms of treatment, I want to make a big picture point. The Hippocratic approach to treatment is not first do no harm. That's what you probably hear. Hippocrates never said first do no harm, and none of his students ever said first do no harm, and it is nowhere to be found in the Hippocratic writings. What is there is, as to diseases, try to help or at least not harm. The term first do no harm was invented in the mid-19th century by a British writer and attributed to Hippocrates. It was actually never, pull it out. You guys have Hippocrates. Pull it out at home, see if you can find that phrase. It's not there. And then people say, if they want to be fancy, they say primum non nocere. They use the Latin, which of course proves that Hippocrates didn't say it because he didn't speak Latin. He spoke Greek. Never said first do no harm, never said primum non nocere. It's not there, and that's not the meaning of his approach. It's not be conservative and try not to use drugs that hurt people. It's actually give drugs that hurt people a whole lot, as long as you know you're treating a disease and helping them. And if you're not treating a disease, don't give them much of anything, even drugs that you think are safe. Now, that's different than the way we tend to talk about this. If you read the Hippocratic literature, you get a sense of that. I won't go into detail. I've written an article on this called Hippocratic Approach to Psychopharmacology, which you can download from that website. The basic picture, which I put on here, is that the Hippocratic approach is to try to treat diseases. So a patient comes to you with symptoms. Your job as a physician, clinician, first of all, this is what you spend your first 2 years in medical school doing, is to find out if the patient has a disease or not. Then your job is, if you find out they have a disease, to look at the scientific literature to see if that disease is treatable. This is where the evidence base comes in and so on. Then you can treat them. That's all fine. This arc is fine. Everyone agrees with that. What people don't seem to appreciate is that many times, if not most times, patients go to doctors with symptoms but have no disease. You're not supposed to treat them, according to the Hippocratic tradition. As to diseases, try to help or at least not harm. That means if there is no disease, you just don't harm. You don't treat, because there's no disease to treat. Drugs work for diseases. Now, it's true, drugs have symptomatic benefits, some of them. Opiates for pain, benzos for anxiety, amphetamines for attention. Isn't it interesting that all those drugs work in normal populations for normal pain and attention and anxiety? Symptomatic drugs are there because they have physiological effects, but they aren't treating diseases. Tylenol reduces fever. Well, is it abnormal to have fever? Is it abnormal to have temperature? If I take Tylenol, my temperature will go down from 98.6 to 97. It's not treating a disease. So yes, it's okay. Sometimes we give palliative treatments when someone's untreatable, but generally speaking, we should try to treat them less, a shorter amount of time, lower doses of drugs. And we should also remember, thankfully, most patients who present with you aren't really sick. Most patients who come to you are not sick. Nature has given them illnesses which go away on their own. So there's the famous saying that physicians know, and physicians' wives know as well, that most things get better by the morning. That's why you say, take 2 aspirin and call me in the morning. It's not because the aspirin works, it's because morning works. By the time it gets to morning, it's done. So, in the case of mood illnesses, these are recurrent episodic illness. What does episodic mean? That means unless they die in the episode, they will be cured by nature. How long does the episode last naturally? 2 to 4 months, 4 to 6 months, based on the various studies for mania and depression. That means if you're seeing a patient who's farther along, you can just wait. I ask every single patient I see, what's the typical duration of your depression? And so frequently they say, it's a few weeks, a month. And they come to me with 3 weeks of depression. And they say the typical duration is a month. And I say, well, great. You'll be cured next week. No prescription, make an appointment for next week, see you then. We have to give credit to nature. That's the Hippocratic tradition. Nature heals. The doctor just assists nature. It's a much more humble attitude than most physicians have. The old classic saying, God heals and the physician dresses the wound. That comes from Hippocratic surgical ideas in the 16th, 17th centuries when they realized that wounds heal by just keeping them clean and putting a dressing on it, not by continually cleaning it out with your scalpel. That makes it worse and worse and worse. We don't have that attitude in psychiatry, probably because we don't see the wound. But we keep giving people drugs and trying to treat every symptom. So that's what the Hippocratic approach is about, minimizing the treatment of symptoms. Now, in our drug treatments, we have a lot of drugs, like antipsychotics in particular, or dopamine blockers, that are used long-term. And I just want to point out that they're based on study designs where only people who respond to the drug can enter the study. Then they get randomized to stay on it or come off. These are called randomized discontinuation trials, or RDTs, or enriched trials. What's interesting is there's almost never been, I think I found one, but there's almost never been a randomized discontinuation trial for maintenance treatment of any drug in psychiatry that ever failed. In fact, the FDA did an analysis, which they're going to publish soon. You know that in the acute depression studies with antidepressants and MDD, half the studies failed, they were negative, half were positive. Well, in their maintenance studies, 15 out of 15 are positive. They've never had a negative study because they all use this design. Same thing with the antipsychotics. There's never been a negative study in bipolar illness of any antipsychotic. The FDA accepts the design, and I'm trying to convince them not to. But one point is, look, if you never have a negative study, how do you have a scientifically valid method? Remember what Karl Popper said? Science is based on falsifiability. If you can never falsify, you can't prove anything either. You get things like withdrawal syndromes with this design. Everybody gets better on olanzapine, then they get randomized to stay on or come off. You notice that 80% relapse within 2 months because they came off a drug which they got better on for a few weeks for severe mania. Well, does that prove that you need to be on it for years and years and years? When you treat somebody in the hospital for 3 weeks, a month, and then you stop the drug and they relapse in a month, have you proved maintenance efficacy? They changed the design. They required 2 months or longer of acute treatment. But still, one of the things that's interesting, and this is based on a paper that Fred Goodwin and I published, if you look at placebo relapse rates in these maintenance studies, if you start out with an initial depressive episode, your maintenance relapse is into mania, the opposite. If you start out with a manic episode, your maintenance relapse 6 months longer is into depression. Whereas in the first 6 months, you relapse into the same episode that you had before the study started, mania or depression. What this, I think, is showing in these double-blind randomized data is that in these maintenance studies, if the relapse happens before 6 months, it's not a new episode. It's the same episode you had before the study started. To really prove maintenance efficacy, you need to show prevention after 6 months. And that makes sense because there's 100 years of natural history data that shows that episodes last 3 to 6 months in bipolar illness, manic depression. And the other interesting thing is that the episode that happens is the opposite pole. Manic depression. Mania is followed by depression. Depression is followed by mania. It's not the same pole, at least in bipolar illness. And what you find with the antipsychotics very frequently is that they prevent mania, but they don't prevent depression in some of these studies, like aripiprazole, for instance. Well, if that's happening, maybe it's just because you are not preventing the maintenance phase of new episodes. Another factor that's relevant to this enriched design, I like to use this chocolate and vanilla cake analogy. Suppose you like chocolate cake, and then I do a study of chocolate cake, and I only include people who like chocolate cake, and then I randomize half of them to getting chocolate cake and the other half to getting vanilla cake. How do you think it's going to go? I don't understand how people can use this design and really take it seriously. Another suggestion is that if you look at this design and take placebo responders, which these Andrews and colleagues in this ingenious analysis did, they took people who responded to placebo in MDD, not antidepressant, and then got randomized to stay on placebo or switch to antidepressant in the maintenance phase. And what they found was that the antidepressant made them a whole lot worse than staying on placebo. They claim that that means that antidepressants actually harm people. It could just be another example that this design never fails. It invalidly makes whatever you select for seem more effective. The one suggestion that supports this is that lithium has both enriched and non-enriched designs. And in the enriched design, it has an odds ratio of 22, non-enriched 2. That means you inflate the effect size tenfold, which is huge. The effect size of 22 is huge. My question is, what if you have an ineffective drug so that the real effect size is 1, but you inflate it by 10? You're always going to see a benefit. You won't be able to falsify. People have been thinking that these drugs just should stay on because you get acute benefit, and they use these designs to support that. But I'm suggesting to you that the designs may not be valid, and also the general concept, like the happily ever after fallacy. You got better on this drug, stay on it and you'll be happy forever, is not a medically proven idea. There's some examples up here where this doesn't happen with steroids, antibiotics, propranolol. And that's all relevant to antipsychotics and antidepressants. I'll just point out that amphetamines are also a problem. They can cause mania, as in this study we showed. They have neurotoxic effects in animals in the brain, which we reviewed in this paper, which you can get all the references there if you like. It's on our website. And a lot of people don't want to admit that. They have neurotoxic effects in the brain. They literally kill neurons. So you're giving a drug for cognitive impairment to people. You're improving their cognitive impairment symptomatically because the drug does that, just like Tylenol improves fever. But you're actually killing neurons, which will make them more impaired in the long run, potentially. And lithium does the opposite. Lithium prevents cognitive neuronal death, that's shown here. That's neuronal death, that's lithium pretreatment. And it's been shown in humans as well, much more. So that's an alternative option. Last thing on antidepressants, I can't not mention, they don't work. The meta-analyses are very clear, relatively clear. This is the most recent, suggesting a very little benefit, very small effect size, if any, acutely. We've just finished a citalopram versus placebo maintenance study and acute study, and we haven't published it yet. I just wanted to show you our results briefly. In 6 weeks, there was no difference. This is citalopram, this is placebo. They were equally improving. So it adds to the literature that there is not really a benefit with antidepressants over placebo for acute bipolar depression when added to mood stabilizers. When you look at maintenance treatment for prevention of episodes, we meta-analyzed that. We published this data in ACTA, and there really is not benefit for prevention of depression either when added to mood stabilizers. There was some increased manic episode relapse. In one of our randomized studies, we also found that rapid cycling patients had 3 times more manic episodes if they were randomized to staying on antidepressants long-term versus coming off. So these are randomized data that show that antidepressants not only don't work in general, but in some patients, especially rapid cyclers, they cause more depression. They cause more cycling into and out of depression. So I think that's a rationale for not using them much, but especially not in the mixed depression patients where I do think that more dopamine blocker usage makes sense. Antidepressants you can certainly consider in your most severe acutely depressed patients, even though they don't work. You can consider it. ECT is probably a better idea if you really want to get them better quickly. But be very, very careful with them. I can't emphasize this enough. I didn't used to say this. I used to think they just didn't work in general. I still think that, but I think it's important to emphasize that they really can worsen the mixed depression patients. And that phenomenology of mixed depression is important for even more caution with antidepressants and for not using them. And I want to remind you in the BALANCE study that lithium prevented depression better than valproate and even better, as good as the combination of lithium and valproate. For depression prevention, lithium was really much stronger than mania prevention. The BALANCE study is a non-enriched classical RCT. There's, again, this false impression out there from these biased, in my view, invalid randomized discontinuation design studies like the lamotrigine data that lithium doesn't prevent depression well. It actually does quite well. Also prevents dementia, as Angst has shown. You have a 22% dementia rate in your 60s if you have bipolar or unipolar depression, which is really high. Population norm is less than 5%. And that's basically reduced to normal with lithium, but with not any other class of psychotropic drug. And this is epidemiologic data. It needs to be confirmed by randomized studies, but there are some randomized studies that indicate some benefit. Now, as people get older, they can't take standard dose lithium, but early animal studies indicate that even concentrations as low as 0.1 have neuroprotective effects. So maybe low-dose lithium can be useful. And this recent meta-analysis showed that lithium of RCTs showed that lithium reduced suicide rates with an odds ratio of 0.13. And it's the only drug that reduces complete suicide in any psychiatric condition. Clozapine doesn't do completed suicide, just attempts. And it's been replicated in multiple, this is actually suicide obviously is an infrequent occurrence in RCTs, so this meta-analysis was useful in providing power to prove it. So it prevents suicide, so it keeps people alive longer. It prevents dementia, so it improves their quality of life. And it really is quite effective. So these are all reasons to think about it, especially at low doses as people age as well. I think we can think about being more flexible about that. The summary of all this is that I think we need to get out of the DSM straitjacket and think more scientifically, and this would include the concepts of mixed depression and mood temperaments. And I think we also need to be more critical about some of the treatment designs, especially maintenance treatment designs, where people are trying to sell drugs as quote-unquote mood stabilizers, and in fact realize that that may not be as effective as it seems, and the lithium data are still stronger, and of course we have these other neurological and medical benefits with lithium. Now I have this one last video. I don't know if it'll work. Let me take off my microphone. This is Martin Luther King, who had severe recurrent depressive episodes and made a suicide attempt when he was an adolescent.
Modern psychology has a word that is probably used more than any other word in psychology. It is the word maladjusted. It is the ringing cry of modern child psychology, maladjusted. Now, of course, we all want to live a well-adjusted life in order to avoid neurotic and schizophrenic personalities. As I move toward my conclusion, I would like to say to you today, in a very honest manner, that there are some things in our society and some things in our world for which I'm proud to be maladjusted. And I call upon all men of goodwill to be maladjusted to these things until the good societies realize. I must honestly say to you that I never intend to adjust myself to racial segregation and discrimination. I never intend to adjust myself to religious bigotry. I never intend to adjust myself to economic conditions that will take necessities from the many to give luxuries to the few, leave millions of God's children smothering in an airtight cage of poverty in the midst of an affluent society.
So I think maybe when we talk about functional impairment and being well adjusted, we should think about that and think about what some of the benefits might be of at least being mildly maladjusted and functionally impaired based on the APA definitions. And instead of ignoring that and writing it off and having bias against it and stigma against it, we should be doing our best, I think, to identify these things honestly and clearly, because we may find that when we do that with this illness, besides being scientifically honest about it, we may hit on some very important cultural and social benefits that we're trying to hide with our current stigma against these conditions. Thanks.